third annual Comer School Nurses event. We are just thrilled and honored to host many of you from not only Illinois, but from throughout the country. School nurses are certainly at the forefront of the work that is being done with our children and for our children in school settings. As many of you know, we're entering into our third year of the COVID pandemic, and we have so many other things that I think children and teachers and faculty are dealing with in addition to COVID that we really wanted to talk about today. So today we're going to start session 2. And this is school nursing for the whole child. Many of you have articulated over the last year that you'd like to get more information not only about chronic disease and some of the major areas where we're seeing some concerns regarding our children in schools, but also focus on some of the areas where we might be able to be helpful around food insecurity, around under-resourced communities where schools are located. And so we're going to kick off today's session with our first speaker, school nursing, looking back to look forward. Alexandra Sophia Sontag is with us today. She's a doctorate of nursing practice in RN and APN. She has lots and lots of initials behind her name, which means she's highly qualified to do the work that she does. She's the program director at the CDC Foundation, Chicago Department of Public Health, Office of School Health. Allie, as she goes by, as I mentioned, is really in this director role for the CDC Foundation to focus on reporting to support the expansion of the Office of School Health at the Chicago Department of Public Health. Allie is a Chicago native and a K-12 CPS graduate. She has a bachelor's degree in cellular and molecular biology and African diaspora and African history from Tulane University. After graduating from Tulane, Allie completed the direct entry master's in nursing program for non-nurses at Rush University. She completed her doctorate of nursing practice and also became a family nurse practitioner. Her doctoral program and project focused on using motivational interviewing in a school-based health center. Ellie worked as a school nurse practitioner for the Chicago Department of Public Schools in the Office of Student Health and Wellness. She first focused on care and coordination and then pivoted to the COVID response. In the time of COVID, Ellie has supported both policy and practice through contact tracing, guidance development, and creation and management of the district's COVID testing program. We are just thrilled and honored to have Allie here with us today. Allie, you're really serving as our keynote speaker for the second session today. And we look forward to hearing your talk about looking back to look forward. I'm honored to introduce Allie, who will join us now, and she will share her slides. Thank you so much.
Thank you. Thank you everyone for joining us here today. So really what I'm going to do is take us a little bit of a history tour, both distant history and then more modern history, to really try to look at what school nursing is historically, but really what we experienced in the last few years and how this can shape us moving forward. So there's my about me. Disclosure, I have no relevant financial relationships with any ineligible companies to disclose, and I will not discuss any off-labeled use or investigational use because I will not talk about medications. So we know nursing serves in this historic intersection between education and public health. And it's a really challenging spot we find ourselves in. So how do we learn from our history to build a healthier future for our students? We're going to kind of break us up into 3 decades, time periods. So we're going to look back at 1700s, early public health, and really understand the origin of public health. Then we're going to fast forward a little bit to the 1900s, where we see the history of school nursing and how do we get here today? Where did this all start from? And then we're going to join our most recent decade of modern nursing. And what did we learn during COVID? And how do we take this with us to really shape our experience and our students' experience? So 1700s, what is public health? Public health, unlike clinical medicine, is really about prevention. It promotes and protects the health of people and also population. So thinking about beyond the individual, but it's also that big level. And the famous phrase, an ounce of prevention is worth a pound of cure, was said by Benjamin Franklin in 1736. He was standing in the streets of Philadelphia and the buildings, everything had burnt to the ground. And he said, we need to replace all of the wooden sidewalks with brick. And everyone said, but that's expensive. No one wants to do it. We're not going to do it. And he said, but if you don't do this today, Philadelphia will burn down again tomorrow. So it's about that early investment. And it's a hard sell even then. And we know it's a hard sell now. So the beginning of public health was actually quarantine and isolation. So everyone's like, this is something new. School nursing, we know this is not new. Nurses, we know this is not new. But this is the words, and we've been using these words since the 17th century. So European cities decided to institute isolation and quarantine for sick individuals traveling, particularly via boat. Then in the 18th century, we started doing this against for other contagious diseases and communicable diseases. And then this also carried on from Europe to the United States. And then it kept growing. So the 19th century marked this revolutionary advance in public health called the Great Sanitary Awakening. They decided that germs were like bad, hand washing was good. This is great news for medicine and public health. So we start doing a lot more vaccine development, public health takes off. So right at this point, school nursing kicks in. 1850, the Sanitary Commission decided that we should educate students on how to maintain their own health. And then really this starts the era of medical inspection. So 1894, Boston appointed medical visitors to go to schools and isolate sick students who shouldn't be there. And then by 1897, Chicago, Philly, New York, all had started similar programs to isolate sick students who were in school. One of the things, they mostly provided these services without compensation. So that is also the great barrier to public health and specifically school health is all of these unfunded mandates. School nursing really began in New York City. So we've got this medical inspection happening, and then 1897, New York hires 150 physicians to do this isolation of students. At the same time, Lillian Wald was working in the Henry Street settlement, which was a revolutionary, cutting-edge public health where they sent home health nurses to homes to provide direct care. So her nurses are working in the settlement and they're noticing more and more kids are home. And they asked families, why isn't your kid in school? And they said, well, they were excluded. Well, how do they get back to school? Oh, I don't know. So you have this idea of medical inspection, the isolation part that was happening on that physician end. But on the nursing end, we were seeing the ground effects of it. So Lillian Wald said, we can fix this. She said, you know what? You're not doing a great job of explaining to people why we're doing this and what you need to do to fix it. So I'm going to actually pay to send one of my nurses to your school to do this work for you. So in 1902, she sent Miss Lena Rogers, who became the first school nurse. And within 6 months of one nurse, absenteeism fell by 90%. New York City was so impressed that they hired 27 more nurses. So we know nursing does this work. School nursing does this work. It works. And we've known this since the very beginning. This wasn't a bright idea. This was data-driven. So it's so successful. New York, LA, Boston, Philadelphia, Chicago, all hire school nurses. By 1914, there was 400 nurses in the city, or New York City. And Lena Rogers goes on and she publishes books. She becomes the first school nurse educator. School nurse and school nurse educator, they always go hand in hand. So that brings us up kind of the looking back. So let's think about modern nursing. This is called the whole child section. So just want to call out if you're not familiar with the whole school, whole community, whole child model or Wisk model. It's the idea that we can only service students in this intersection of both health and education if we think of them in this kind of holistic view, where they are the center, and our goal is to have them be healthy, safe, academically engaged, supported, and challenged. And we do that by creating policies, processes, and practices. Oh no, is my presentation moving slow? Can someone throw in the chat if my slides are not caught up? I'm going to take a pause here for just a second.
It is on the slide, school nursing spread nationwide with the map on it. And now it just caught up.
Thank
This
you.
is 2020's modern school nursing. And now it says
There we go. Now we're
whole
caught up.
school, whole community. Okay.
Perfect. Thank you. I had a feeling that's why I've double screened. So this is the Wisk model, and this is that idea of that safe, academically engaged child. And we support them through coordinating of policies, processes, and practices. And then there's all of these components. School nursing participates in so many of these components. And we also recognize that the child is sit within a community, and that's really what HomeWorks is doing, right? It's part of that community medicine. It's surrounding that child in care as well. So we're going to take this model and we're going to think about what school nursing is. Now, it's important to think about the Wisk model because the NASN framework is set within the Wisk model, so it perfectly matches up. So before COVID, people thought that school nursing was mostly about 504 and IEP work, maybe some first aid, but we know that's not what school nursing is designed to do, much less can do. So NASN set this 21st century framework of practice, and it really calls out how school nurses can really practice at the top of their license and service their community well. A little bit of a COVID timeline. Spring of 2020, we all go remote for the most part. Fall of 2020, some schools come back in person, but some are fully remote or hybrid. Winter of 2021, most schools return in person or in hybrid, and vaccine is widely available for adults. Fall of 2021, most schools return in person and pediatric vaccine becomes available. And this kind of ebb and flow has really shaped our experience in schools. So what I'm going to do is I'm taking the framework and I'm thinking about what we did during COVID. So nurses wrote standards of practice, right? We wrote new ones for COVID. We modified and adjusted constantly for this. We did care coordination, right? How do you figure out how to do care coordination remotely? How do you connect families to healthcare when a lot of healthcare systems have shut down? How do we lead, right? We're leading district level activities and responses. We're collaborating with health departments. We're serving on advisory boards, building contact tracing systems, right? Quality improvement. We're taking things we learned that first year and applying it to the second year. And we're doing community health and public health, right? Testing, education, vaccines, all of that is public health. So school nurses did a lot. So let's take some lessons learned from both our far past and our most recent past. And I've broken it into 3 big groups. What have we learned for parents? How do we improve systems, support staff, policies, and practices? How do we support the whole child? How do we set up our students for success when things are constantly changing? And then how do we make things better for ourselves? What are lessons learned for nurses? And I think that's really important to be self-reflective. So starting with our child, our whole child who's at the center of our conversation. These are some big high-level take-homes from my experience that I learned. Create consistency whenever possible. It's not always possible, but if you can be consistent, take that opportunity to be consistent in whatever it is. Scheduling, messaging. We know children love routine. We should be leaning in as much as we can. Students are more flexible than adults. This is something we have learned deeply during COVID. We also want to think about that student within the context of their whole life, really thinking about that whole child, right? We saw this during COVID, I think, more than we have historically. There's always been 1 or 2 students where you're like, oh, wow, your home life is challenging, right? And you could see that reflected in their appearance, in their attendance, in a variety of factors. But COVID was unique because we actually were looking into children's homes. When they joined remotely, you could see if there was chaos in the background, the level of care and attention. And so it really, for me, illuminated a lot of our students' out of school life. And so it's really an important reminder for me. Another great call out from our first group, our first presentations, health is more than physical health. Mental health is vital for all of us and particularly for our students. So taking that time and folding that into our practice when we're asking how people are doing and if they need support, thinking not just about their medical needs, but they're larger holistic needs. And then it's never too early to start educating on fundamental health skills like hand washing, which we learned during COVID, right? I learned a lot of adults didn't know how to wash their hands. This is something that we can start young and start having those conversations with our youth so that they're prepared for whatever, but more so just because it's best practice. So lessons learned to support schools and parents, implementation of evidence-based practice in all things. If you can pull in evidence-based practices into your work, it makes you stronger. It makes a stronger argument for why you are doing the things that you are doing. It also gives you backup. It gives you support for those decisions. And that really comes to this idea of standardizing guidelines for clinical practice. In your space, in your work, in your school community, creating standardized guidelines makes everyone agree, right? Whether or not you're a teacher, a nurse, a principal, if you've created standards and you've brought them to your school and you said, this is the standard of care, you're pulling everyone together and you're speaking from the same narrative. Because that is the thing that I learned during COVID. In nurses, we say contact, droplet, airborne precautions. We know what those words mean. I realized other people didn't. And so creating those standards of clinical practice allows you to fold in others and make sure that everyone's speaking the same language and that you have something to reference. Similarly, explain the why behind guidelines. Tell a story. Because people need to understand, you need to take them along on how we got here today, on why these things matter. But also, if you cite your sources, you then can reference them and update them on a really easy basis, especially as things are changing constantly. Linking to the CDC page where you pulled that from means that if you click on that link again, you are taken to probably the new guidance if it gets updated. So really trying to future-proof is through this telling of why, is keeping track of where you got this information from. And then similarly to our children, create consistency whenever possible. With guidelines that are changing, at least have the where and the how they get updated to be consistent. Is it a letter? Is it a website? How are you communicating? And if you can keep that consistent, they know what to expect from you. And then speak in plain language with clear next steps. Similarly to contact, droplet, and airborne, nursing has a language of its own, and we use it very comfortably. And I've realized that's just not a language that everyone else speaks. So whenever you have the opportunity to speak plain language, for me, if I translate something into Spanish, because I personally have about a 3rd grade reading level in Spanish, if I can't translate the sentence easily into Spanish for myself, I know that I've written it too difficult. And then make space for difficult conversations, right? Have open door policies. I know for me, I was approached by several nurses who were working in the district with me who were very nervous about getting vaccinated. And they called me. They didn't call their boss. And I had given a presentation and they said, talk me through it. Talk to me like you would talk to your mom. And I don't know the outcomes of those conversations, but I was really grateful that they had brought them up for me. And then lessons learned to support nurses. Understanding how funding works for your district is important. So here in Illinois, many public school nurses are partially funded through Medicaid reimbursements, and the state is expanding what can be reimbursed for, so it's opening up a lot more funding opportunities locally. This is important. This goes back to that unfunded mandate from the original Lina Rogers, right, who was a donated nursing time. If you understand how you are funded, you can understand why maybe they can only afford one. You can create opportunities to create more funding. Also, if there's funding that are coming in through your documentation, through your work, that could support more staff, more time, it supports your argument that nursing is not only vital, because we know that it is, right? 90% absenteeism in it so quickly, right? That's an amazing drop. We know that it's important, but money talks, and we need to be able to represent ourselves well. and then bring nursing voices to the table and making sure that you're amplifying diverse nursing voices as well. This is something that I try to do professionally. It's very important that we have nurses pulled into conversations whenever we can. And as a fellow nurse, I make sure that I'm amplifying the people who are on the ground doing the work. And these other 2 pink ones are quite frankly just for you. Be a perpetual learner. This is something that I strive for every day, and take care of yourself. COVID has taught me personally that I need to listen and take care of myself and listen to my body. And I want to pass that lessons learned on to all of you as we think about back to the school year, back to school, and all of the stress and pressure that puts on us. Make sure that you are taking care of yourself. There's my references. And I do want to just thank all of you for everything that you do every day to keep our students healthy. And thank you so much for having me.
Of course, Ellie, thank you. What a fantastic presentation. We certainly need to look back to look forward. I think what's great about presentations like yours is that they give us so much context and provide us such information historically that informs what we can do as we move forward. So thank you. Our next speaker, we're just delighted to have her. We're going to talk about increasing access to healthy choices, childhood obesity. So Vicki Gainsberg is a dietitian. She's a registered dietitian with over 20 years working in pediatric gastroenterology at Comer for 10 of those 20 years of experience. Vicki has a wide variety of GI conditions that she is familiar with, including celiac disease, food intolerances and allergies, irritable bowel syndrome, constipation, reflux, G-tube feedings, and along with weight management. Here at Comer, Vicki is a part of the multidisciplinary clinic for many of our doctors and works with a liver specialist once a month for weight management in children. Vicki's passionate about helping children reach their greatest potential through nutrition, and we're thrilled that she's going to be talking to us today about better food choices, nutritional management of children, both in schools and out of schools, and also touching upon the other epidemic that we're dealing with today, which is childhood obesity. Vicki, thank you so much for joining us.
Okay, thank you. Oh, let me just get my screen up. Okay. Can everyone see this?
Vicki, it looks wonderful. Thank you so much.
Okay, perfect. Thank you so much for having me. I'm thrilled to be here today. And today I'm going to talk about, as Peggy said, increasing access to healthy choices, focusing on childhood obesity. Okay, disclosure, sorry about that. I have nothing to disclose. I have no relevant financial relationships with any ineligible companies, and I will not discuss any off-label use or investigational use in my presentation. So my areas of focus today are I'm going to briefly go over childhood obesity, and then we're going to get into some healthy choices through access and approaches, and then how you can help with these children as well. So just a background, I like to talk about a few facts about childhood obesity. You know, the prevalence rate since 1975 has nearly tripled. And children between the ages of 2 and 19 are at about 20% are considered obese in our nation. And that to me is a staggering problem that this number needs to decline, not increase over the next years. Obesity is defined not just by your weight, but it's defined by a percentile of height and weight. It's a measurement. And this is what we look at here at Comer. And so when you have a BMI, a child has a BMI between the 85th and 94th percentile, they're considered in the overweight range. And then above the 95th percentile, a child is considered obese. Obesity is not a forgiving disease, and it does come with a lot of risk factors, especially starting in childhood. It's not just, something that occurs as an adult. But unfortunately, a lot of these children with obesity are at risk for other diseases. Here's just a few. They're higher risk for asthma, sleep apnea, bone and joint problems. Type 2 diabetes is a huge concern, even heart disease, and fatty liver disease. In my clinic that was mentioned, we see a lot of these kids come in with elevated liver enzymes, along with a lot of these other problems. And so this is something that really needs to be addressed. A few statistics about obesity in Chicago, children, which is also a very concerning, is their diet. So 40% of children's diets come from unhealthy added sugars and unhealthy fats. About 70% of students in Chicago do not eat the recommended number of fruits and vegetables per day, and that's probably nationwide. Most children do not get enough fruits and vegetables, and that's what I try to focus on. 1/3 of Chicago high school students also drink at least one or more sugar-sweetened beverages a day, which is to me very concerning. And then again, getting into access issues, this does play a primary role in some of these obesity challenges. Next I'm going to talk about a few barriers to access. We're going to get into briefly because I'm going to focus more on some education parts of it, but basically food insecurity. And this is when an individual does not have the adequate access to affordable, healthy food. Is highly associated with obesity in children. Poor nutritional quality of these food choices that are available to them. Oftentimes these foods are super high in sugar, they're ultra processed foods, high in fat, and they're not even looking at, what's in this package, the nutrition facts. Also, lack of education has also been shown to, as a barrier to preparing fresh produce. People just do not know how to cook. They don't know how to prepare the produce. They'd rather go and get these processed packaged foods. And then of course, reduced access to fresh produce in low-income neighborhoods is also a huge concern. When you go to these areas of underserved communities, what you normally see a lot of is these convenience stores and gas stations on the corners. And these children are going into grabbing, chips and cookies and, what do you see in the gas station convenience store? Nothing healthy. There's really a limited range of food items. They're high in calories, high in processed sugar. And these stores are also really less likely to stock any healthy foods. And if they do stock them, oftentimes they are a lot more costly than if you go to a large supermarket. Families I come into contact with, they oftentimes only are going to the grocery store or supermarket once a month. So they might go and grab their, produce, and then they're out. Once they're out, they're out. And this is where they're shopping, is these small little community stores. And a lot of times they're not getting what they need from them. So next I'm just going to talk about increasing access through a couple different routes. One would be community organizational, has been shown to help, and then more of an interpersonal individual level. So, on a community organizational level, there's food banks, which has been, really great for these underserved communities. This helps, provide some fresh foods, minimally processed foods, and this has been really shown to be helpful with getting some good, healthy items to these families. There's also these local fresh food markets that are starting to come in that communities are getting more of, and these are more of a low cost, discounted, mainly fruit and veggie markers that we're trying to get into some of these areas that don't have available, aren't able to get to these large supermarkets where there's more choices. Also culturally tailored groups, which is something where we need to provide healthy education in native languages. We can't just do, we have to focus on these different cultures that come into these communities and trying to provide healthy materials to people to know what is available to them as well. In-store promotions has also been shown to be helpful, where we get these fruit and veggie sales and focusing, this is what I like to also focus on with my families, is where can we find these sales, and let's stock up, whether it be like from frozen vegetables or frozen fruit. These stay for long periods of time. And also social media programs. This is huge because everyone's on social media nowadays, but promoting these healthy eating behaviors with various different educational activities And also has been found recipes, getting these people healthy recipes can really make a difference too. People love recipes. You know, I provide different recipes to my families and they're thrilled, they're excited to try some new things. And moving on, school programs, you know, this is huge too, you know, with these children, promoting healthy school lunches. You know, CPS has a school lunch program. I think there is some room for improvement with a lot of with that program, getting some more fresh fruits and veggies. I mean, they provide some, but I do think there is room for improvement in that aspect. School gardens. This has been a big thing. I think that I know of in Chicago. Local school gardens. These kids are growing. They're you know, harvesting these fruits, these vegetables, and using them in cooking classes and trying to find recipes and really promoting getting those healthy foods into their diet. And I think this is becoming more up and coming, especially in the Chicago area. Recipes, again, you know, recipe cards, families love, kids are very excited about getting different recipes, handing out in different grocery stores, community centers, and food banks has been really helpful. I feel like to getting some healthy, knowing how to cook, knowing how to get some healthy ideas for using various different produce. Because a lot of these families just stick with maybe one or two things, and then they, you know, don't like to venture out into using different things because they haven't tried it, they're nervous about it, they don't know what it tastes like, and they don't want to spend the money. Another thing that's been shown in various communities is doing taste testing events of healthy foods. You know, some people are like surprised. You're like, oh my God, this actually tastes good. And this also will encourage, you know, choosing healthier foods, getting those healthy foods in to, you know, get a healthier diet. Demos too. Community food banks have been trying to teach pantry clients healthy cooking ideas, healthy recipes, and so forth. You know, the other thing is just reducing the cost of healthy foods. You know, a lot of communities now here in Chicago are bringing in local farmers into these communities, and they're trying to provide more seasonal produce. So the produce is, you know, less expensive, and then, you know, people can taste the produce and see, you know, if they like it. And I think this encourages, you know, trying new things and experimenting with more healthier foods in general. And, so this is a study I just wanted to talk about. I thought it was really interesting. It's called the Be More Healthy Community Kids. And this was, you know, a community-based multi-level obesity prevention study that was done to help improve healthier food purchasing and reduce sweet snack consumption in the low income African-American youths. And it was over a 2-year period. And it involved all these different programs, youth-led education and recreation centers, in-store promotions, and then also social media programs. And it was just the education was promoting a healthier alternative to beverages, snacks, and then sharing also these promoting healthier cooking methods, and of course using these healthier ingredients. So it also involved, you know, a lot of some policies too, because this is a big part of it is policy change, starting from up above. But it involved improving supply to healthier options at these corner stores, carry-out restaurants, and then they also provided taste tests of healthier options. Posters, educational sessions, all these things were provided. And then of course they also work with these key city stakeholders to support policies for healthier food environment. And the results were wonderful. I was like really thrilled to read about this, and it really showed the intervention group purchased almost 1.5 times healthier food versus the comparison youth group. So, you know, as we know, like educating these youth on healthy intake, what it is, you know, and getting these foods available to them is key to a healthy diet, preventing this obesity, preventing these excess calories from being continuing on in their diets. On a more interpersonal educational level, I like to, which is more like what I do more so is, you know, this education. You know, peer-led education in kids is wonderful. I think it really helps with like them learning. They're more interested in I guess, taking on what it is when they hear from different peers and stuff. Hands-on activities, again, interactive cooking, taste testing. As I feel like this is a trend, but like getting these kids tasting these healthy foods can really make a difference. Gardening, again, taking a hands-on approach can really help improve these kids' diets. Growing, planting, using these fruits and vegetables to make healthy recipes. It has also been shown nutrition education by far is a main factor in helping increase the fruit and vegetable consumption in these children and families, because it really stems from the family as well. It's not just about the children, but it's about the whole family has to take on this healthy lifestyle. Cooking demos too, it can also help, again, improve these cooking skills to low-cost meals, helping to make low-cost meals, I'm sorry. Because, people, what they do a lot of times is they my families, they go out and they go fast food. They go to these fast food restaurants, these local takeout restaurants, and they're probably spending more money there than they think than they could be when they're cooking real healthy food, going to the grocery store and, cooking these foods and then when they start cooking more, they start using more variety of vegetables and fruits and different grains and proteins and all that good stuff that is really important to implement for a healthy diet and prevent those, those excessive calories from all those processed foods, packaged foods, and those tend to be more expensive as well. Label reading is also so important in these processed foods, packaged foods. These kids go to the local gas station, convenience stores, and they grab maybe like what they think is like a single serve of like a package of whatever it is, a chips or cookies or sugary, desserts. And oftentimes they think it's one serving, and it could be 3-4 servings in that package, and they're just eating it all. I like to focus on that label, and really, what is that label? What is on that label? We have that label, and let's use it. Added sugars, and I point that out because that's so important. We see so many added sugars in processed foods, fats, and then the overall calories and serve size is so important when we're dealing with these packaged foods. We have the tool, and we just have to show them how to use it, how we can help with this and help decrease consumption of these foods that are just really calorie dense. And individual education, continuing, this is a great platform, My Plate, and I'm sure you all are aware of this great diagram. I love using it with my children, my families, but it's all about focusing on a balanced diet. There's no diet fads here for children. We don't want them on like a keto diet or low carb. This is not what we want them to do. We want them to focus on a healthy lifestyle, healthy diet, and a balanced diet. And, the main thing here is getting those fruits and vegetables in. And this can be a lofty goal for some. Some people may only be eating one fruit a week or not eat no vegetables. So, this is where I focus my training to them, is getting those fruits and vegetables and how we can do this. Because this is where we need our focus to be, is those fruits and vegetables. This is where we're going to get the healthiest foods in, especially the vegetables. So I always say, 5 fingers, let's get those 5 fruits and vegetables in per day. And if we can't do 5 right now, we work up to that. We get, start with 1 or 2, and we get to those 5 per day. Sometimes with little kids, I say, let's pick a color. Let's pick red, so let's do, a few red colors. Orange, we can do orange, and, the different pinks, in there, but, let's focus on a color and let's try to get those different, there's lots of fruits and vegetables with red in them. Again, lean protein choices I get into. Calcium is so important for these bones to develop and grow and stay strong. So I encourage calcium-rich foods that are healthy. Because some of these, again, added sugars, yogurts. Oh my God, some of those yogurts people are eating just have full of sugar. Chocolate milks, flavored milks. There's so many things that ice cream that have a lot of calories. So I focus on the healthy ones. Getting those grains in, but healthy grains, those fiber-rich grains. This can make such a difference. This actually helps lower the blood sugars because you get more fiber in, those blood sugars don't go high so quickly. And then healthy fats are important, just for good brain development. And we want to get those omega-3s in, and I focus on getting some of those and how we can do that. So it's really individualized, but this is like the main thing that I try to encourage with these children. This is something, oh, are we past our time?
We are approaching our time, but that is okay, Vicki, and you'll be participating, of course, in our panel discussion at the end of the session.
I'm so sorry. Okay.
Don't be sorry.
You're more slides up, but I just want to
rocking.
mention one more thing. So this is another message I use, but we have, I did start in the beginning, but we have a obesity, a weight management clinic. And I wanted to just, I can go forward that this is so, so important. We have this once a month. Sometimes we see kids randomly throughout the different clinics I have it with a physician, and we focus on healthy diet education, individual diet plans. And this is, if you guys know anyone or have anyone that you feel like meets these criteria or just need help with, please refer them to me, to dietitians in general, wherever you live. This can be so helpful for these children. And thank you so much. I'm so sorry for going over.
Vicki, you rocked. Thank you so much. I think the key here is Vicki's going to be on hand to answer some of these amazing questions that are in the chat. She'll be here as part of the panel discussion. And Vicki, the most important thing that you said of all the things that you said is we need to be thoughtful and cognizant about the needs of these kids now rather than letting this go. And that we have an obesity clinic for children. Parents can potentially refer. They don't need their general pediatrician to refer. You can contact Vicki if you have questions, and you can ask more questions as school nurses. One of you asked today about how you engage families in a discussion when you know the BMI is high in their children. I did this recently, and we'll talk about that more during the chat. So thank you again, Vicki. Amazing, amazing presentation. And I know you'll be back in just a few minutes. Our next speaker is going to focus on trauma care in schools. So Stacy Ward-Barron is an advanced practice nurse. She earned her Bachelor of Science degree in nursing from the University of Arizona in Tucson and her Master's of Science in nursing from Penn in Philly in 2015. Stacy completed a fellowship in pediatric emergency medicine at CHOP, the Children's Hospital of Philadelphia. Stacy's board certified as a pediatric acute care nurse practitioner. Stacy's focus is pediatric emergency medicine with extensive experience with the pediatric trauma team. She's worked in pediatric settings in hospitals and in schools, and she's currently working as an advanced practice nurse in pediatric emergency care at the University of Chicago. So Stacy, can we see you? Are you with us? I think you are. There we are. Hi, Stacy.
Hi, can you see me?
We didn't until now. Thank you for joining us, and please go ahead and pull up your slides. And again, if we don't have enough time for your presentation, you got about 20 minutes, we are going to, for sure, engage you in a conversation at the end of this session. So Stacy, you've got some awesome experience, and it was really cool to invite you to speak today. And you had mentioned that you have experience as a school nurse. So that's really cool. So thanks for talking about trauma and what we need to learn. Thanks again.
Yeah, happy to be here. It's really neat trying to bring in all the different components of what I've done in my career so far, first as an RN, working in the school setting, and now kind of that got me interested in pediatric emergency because I saw so much and triaged so much in the school settings. I predominantly worked in the high school setting. So yeah, it was really fun. I hope I'm sharing these okay. I don't want to get this thing.
They look great. Go ahead.
Excellent. Okay. I'm going to touch on a couple of different aspects of trauma in the school setting. The obvious first ones are going to be your trauma-related incidents that you're going to encounter. And just here on this slide, there's just a list of them: falls, fights, fractures, gunshot wounds, pedestrian struck, MVC like versus a bike, kind of like a walking pedestrian versus on a bike as well. Fires, if there's a fire in the school, internal, external injuries, and then sports related injuries. I kind of wanted to highlight that a lot of the traumas within those are going to be very similar complaints that you're going to be dealing with, or that you need to be aware of, that you could potentially see in the school. And a lot of that comes with, as a school nurse, you're kind of you're one of their primary contacts. You're going to be their first kind of their first response, their first go-to when something does happen. They're like, call the school nurse. You know, you're their own personal 911 in a way. And so if you have children coming to and from school, that's when you're going to need to be aware of like crosswalk incidents, kids traveling on their bikes. Anything that happens around the school setting is kind of your, that's your setting there. That it's all encompassed within it. As a school nurse, I saw a lot of different traumas that would happen kind of at the start of the school day and then at the end of the school day as well. Within these incidents that you see, you're going to get your head injuries, your musculoskeletal complaints. That's going to be your fractures as well, sprains, strains, deep bruises, blunt force traumas, dental traumas happen in school as well. Head injuries, eye injuries, lacerations. You got facial trauma, anything that happens in the face, and things to kind of be aware of within that. It's such a condensed time period that I have right now. So I'm gonna kind of give general overviews of things, and then kind of move through it a little bit more quickly. Things to reiterate to kids that you should always have in your like education setting is like with parents and things like that, helmets, and then safety seat belts, things like that are super important. If you're doing preschool stuff, you're going to be doing car seat education, different things like that as well. Because the regulations for car seats are pretty pretty varied now. They've expanded to like it's more weight based versus like age based. So then within your trauma related incidents, you've got I like to give you guys this tool to use. It's called the Pediatric Assessment Triangle. With the more scarier traumas that you're going to see in the school setting, you need to have something where you're like, this is my go-to. This is what I'm doing in order to properly assess the patient and get as much information as I can, because you're going to be the one kind of calling 911, communicating with the parents as well. So this is the Pediatric Assessment Triangle on this slide. And it talks about you know, appearance, work of breathing, and circulation to skin. We use this in the emergency department too when we're triaging. So triaging is like when you see somebody for the first time, you're going, okay, what do I need to know right away? Sick versus not sick. And you do that in the schools a lot because it's going to gauge how you rally your troops. The school setting is different and a little bit more nuanced because in the hospital setting, you've got a whole team around you. Okay, it's working with you. And in the school setting, you're somewhat solo. So you need to know what help you need, when you need it, and how to get it as quickly as possible. So in order to do that, you have to be able to communicate effectively with your outside supports. 911 is kind of going to be your best friend. I remember when I was a school nurse, I knew the rotation. I knew my engines that would come to my school and help me out because they were the ones helping me out doing breathing treatments, you know, splinting, getting these kids going. If there was fights, things like that, head injuries, lacerations, you're going to need help controlling the scene, controlling the bleeding, things like that, making sure these kids are okay. Sometimes you can deal with it all, but when you think about it, you've only got, you know, X amount of time and to do some interventions, but then we also have to be notifying the parents as well. And so it's important to get your external staff, you know, mobilized to help you out with the situation. So then you can kind of focus on making sure the kid's okay, the parents, the teachers, because you're dealing with a lot that's going into this situation. I had one just anecdotally, kind of encompasses quite a few things in this presentation. I had a child who was riding his bike. He was an adolescent. He was a 17-year-old male, and he was riding his bike into school, had gotten onto school property, had bumped his bike and landed on the middle bar in between. And so he suffered a straddle injury. So he was bleeding. 3 kids ran into the school nurse's office. He's bleeding. Everybody's freaking out at this point. So you gather your stuff. You want to make sure you always have your cell phone or a walkie-talkie or first aid kit because you don't know what you're going to get. So you run out there, you got your gloves, you want to get your PPE ready. And he was bleeding. We had to quickly assess it. Maintaining privacy is super important in this age group as well. And you know, quickly assessed it, made sure that he was okay, call 911. We don't know the extent of the injury, but he according to my pediatric assessment triangle, he was alert, he was breathing well. He was a little shocky looking just because he's like, oh my gosh, you know, the nature of the injury, it just does something to these kids, okay? And blood is scary for anybody. But otherwise he was doing okay. So I knew I had a little bit of time to react in this situation. So I gave 911 a call. Once I got there, I kind of covered up the bleeding, tried to control it as best as possible, got the parents in there as well, quick, and then got him shipped out to the hospital. That's just one of those, just anecdotally how you can kind of apply it in that situation. This is just to kind of, these situations are going to happen. I have loads more stories like that of like, oh my gosh, and you're alone half the time kind of responding to this. So you do kind of feel the stress of it. This kind of brings into the next part of it, which is return to school care for the post-trauma student, the one who's been kind of in these incidents. This is going to happen. You're going to get tons of kids that are going to suffer from traumatic incidents, and they're going to want to return to school. And so your job is to try to help. You're kind of an ally for these parents and for their medical home. You act as a part of their medical home in the school setting, ideally, right? These are all ideals. Sometimes you're the only school nurse and you're just doing the best you can to stay organized and make sure the information is there when you need it, to try to be sure that you can provide the care to these students and you're at least up to date on everything that you need to know, and you know where you can find it. You don't got to memorize all this stuff. You just need to know where the information is and make sure it stays organized. Part of that is going to be trying to communicate with the family. It kind of make sure that they know that their back to school planning is almost as important as their back to home planning as their discharge from the hospital. There's going to be follow-up visits to deal with within the school setting. You're going to have to, you know, you're going to kind of be the hub. They're going to go to the school nurse's office. Oh, I've got a doctor's appointment. You're going to want to check in with them more frequently. Special accommodations. You will be involved in the meetings in the schools that are going to be providing with these legal documents that are going to ensure that the students have the accommodations that they need in order to be successful despite their new medical needs. So that comes up with 504s and individualized education plans, IEPs, and those are legal documents. Those come with meeting with the families and the teachers, care planning, updating the medication list, making sure their allergies are all updated. And really, your whole goal in it is to make sure that the patient is safe, the student is safe, the staff is safe. You're able to give them frequent check-ins, that you maintain that kind of relationship with them as they go through that like really acute phase of re-entering into the school. And it becomes less and less as they get more okay and accustomed to it. But you just want to be able to provide that anticipatory guidance for those families. The other kind of component, that was a lot of information. I'm going to keep moving forward for time's sake. But the other component that I kind of wanted to touch on, even just briefly, is trauma-informed care. And as, unfortunately, in the school settings, we've all kind of been, students are now, in a large part, definitely being exposed to trauma on a regular basis. You know, because it acts as a part of their community. They're exposed to, you know, their own trauma within the home that kind of affects their school setting. You know, it's an extension of themselves. The school is, it's an extension of their home half the time. And sometimes it's the only place that they feel safe. So being aware of that is important. And the neat part about trauma-informed care is that it's kind of like, as a provider, as a healthcare professional, it shifts it from what's wrong with you to what happened to you and how can we help you cope and how can we help you navigate these things. Trauma-informed care in the health office. This is from the guiding principles of trauma-informed care. And it's just a broad overview of how you can maybe apply those within your practice in the healthcare office. And the principles of that is safety, making sure that patients, students, staff, it extends all over, feel physically and psychologically safe, making sure there's trustworthiness, transparency for the parents, for the students, for the staff, that we're all on the same page, making sure people feel supported, collaboration with teachers. You're going to be working side by side with these teachers. You're going to be allies. And it's super important. You want to empower your students, you want to empower your staff to function at their best abilities. And you want to find out how to build resiliency in your schools by highlighting those strengths that are so unique to each different, can be so unique to each different culture, to each different, section in, especially like I know in Chicagoland, there's a lot of different cultures that are being represented, and a lot of it is neighborhood based, and it's very interesting and very unique. And as school nurses, you may or may not be a part of that community that you're going to be serving. So your task is kind of to be aware of your own biases. It's all about cultural responsiveness. It's kind of being aware of your own biases, being aware and reflecting on your own perspectives, and then, using those to provide trauma-informed care, but also kind of checking those at the door so that we can then look towards the people that we're serving and say, I know where I'm coming from. Let me learn and help let me meet you where you're at. I want to help you, and I want to create a safe space where we can all appreciate and respect each other's growth and journey. And it works really well. And it's actually more and more important because we have so many diverse and unique experiences in life, and so much more acceptance is being fostered, which is amazing and has really helped the youth community in a lot of ways. There's a mental health crisis in the youth community, especially in adolescence, and it's becoming an increased need for fostering resilience and being aware of these biases, because you can decrease suicidality, you can decrease, I'm not sure how to I don't know how to answer the raised hands, but I see you. You can decrease suicidality among teens by even just setting up a non-biased open platform for them in your health office where they can feel comfortable coming and talking to you about anything, no matter what. And part of that is also about trauma-informed care, right? In our current climate, kids are traumatized on the daily. People are traumatized on the daily, and it's not even happening in that real moment, but we're looking at big scale. We're looking at school shootings, mass shootings that are happening outside the schools, and gun violence. Gun violence is leading cause of death among teens. I believe that statistic is correct. It's kind of covered up on my screen, but is leading cause, right? And we're dealing with it all the time. And I see it a lot working in the south side of Chicago. There's a lot of gun violence that's happening too. It's hard for these kids. I'll see it, in the emergency department in the trauma setting. Smaller scale, you're looking at your neighborhood violence, domestic abuse, drugs and alcohol. Effects of that can really impact it. So these kids are coming in and they're bringing all their baggage, and all they want to do is put it down and just learn. And how can you give them that place? How can you support and promote and give them that place where they can just put their emotional bag down for just a little bit and focus on learning? And as a school nurse in the health office, you can be that to kids. You'll have that platform. It's a really wonderful and unique experience. I wanted to share, I know I'm kind of running out of time, but I did want to share another tool for you guys. It's the ACEs assessment tool that you can use if you're seeing a kid that's a recurring kid coming in and out of this nurse's office, like, hey man, what's going on? You might want to use this tool, and it talks about, it's kind of a way to gauge adverse childhood experiences. It's called ACEs, and a lot of people use it to gauge their level of trauma in their lives. Every human is going to register on this ACEs scale, every human. And so it's a really useful scale, and we can implement it in the school settings, and then you can have documentation, be like, listen, I use this as a clinical assessment tool, and you're kind of documenting these things, and then you can start to put in place, your plans, care plans, things like that. You can help them navigate. Hopefully you'll have other resources, social work, your counselors, teachers are always like the salt of the earth, and they want to help. They want to get these kids learning, and that's like kind of the goal of it. I know that I don't know how much time I have left. I haven't gotten I can talk a little bit more about these things, but I'm just not sure where I'm at with time.
You have 2 whole minutes.
I
However,
got 2 minutes?
You got 2 minutes. However, you can take time as well during the chat discussion that will follow our speaker.
That's fine too. Yeah, we can do that. And that comes back on at
12:35.
At 12:35. Okay. Whatever you guys want to do. I mean, I kind of tried to push through quickly so that I wasn't taking up too much time, and I'm happy to answer questions in the chat at 12:35. That works for me.
Fantastic. Thank you so much.
Thanks, guys.
Wait, nothing is more valuable and important than Stacy right now. I mean, literally, Stacy, I've like underlined and put an asterisk next to your name so that I could occasionally ask you a question. As a mom, as a nurse in my own community, super valuable. Thank you so much. Our next speaker, we're super excited to have Christine O'Malley with us. Oops, somebody's asking if 12:35 is a break. You know what? You're right about that. Our panel discussion actually starts at 12:05. Thank you. Thank you. So at 12:05, we're going to start our panel discussion, and you are right. We will have that break at 12:35. Thanks for the clarification. Christine O'Malley is a nurse practitioner. We're super excited to have her with us. She is with the University of Chicago Department of Obstetrics and Gynecology. She holds a master's degree in nursing and an advanced practice degree in neonatology as a nurse practitioner. She's a graduate of the McLean Center for Clinical Medical Ethics at the University of Chicago, where she did a fellowship. And she's been a part of the section of neonatology at U of C since 1987. She's currently practicing as a neonatal nurse practitioner. Her current role has been really, focused on a number of areas, including screening neonatal patients in the Comer ICU and focusing on a study that she's been working on called Hunger RX. Food scarcity among children is a really, really important piece of our work at the University of Chicago. Helping you to identify it is one of our goals today. And we're thrilled to have her, as well as Melissa Grana. Melissa Grana is a community resource navigator for Feed First at the University of Chicago. Ms. Grana graduated in 2016 with a degree in molecular and cellular biology and chemistry, with a minor in chemistry at the University of Illinois, Champaign-Urbana. She discovered a passion there for biological sciences, research, and public mental and physical health and how they intersect. Melissa is part of the Lindow Lab. Dr. Stacy Lindow is really just an amazing researcher and community engagement champion, I would say, focused on the needs of communities and how we can help engage them in conversations to provide community resources. Ms. Grana conducts clinical trial recruitment, and she provides resource navigation services for 2 NIH-funded social care intervention trials, including the Feed First Food Pantry program at the University of Chicago. She has co-authored and has an accepted publication to the American Journal of Public Health entitled Feed First, No Questions Asked: How a Hospital-Based Food Pantry Program Grew and Its Impact During the COVID Pandemic. Melissa and Christine, we're so happy to have you guys here, so take it away.
I'm so sorry. Can you hear me?
We can.
Oh, great. Okay. I'm sorry. So start the slideshow. I'm so sorry. So I'm Christine O'Malley. I am a neonatal nurse practitioner. I work in the Comer Children's Hospital neonatal ICU. The topic of our talk today is about food insecurity in the clinical and hospital setting. So some of our objectives for this session are to define food insecurity and its impact on childhood outcomes in the hospital, describe food insecurity among hospitals and underserved communities using data generated from our prior studies of patients and caregivers on the south side of Chicago, and describe food insecurity among our most recent initiative, which is the Community RX project and the study participants, who include many parents of school-age children living on the south and west sides of Chicago. Disclosures, sorry, I have to get to the disclosure slide here. So Dr. Stacy Lindow, who is amazing, is the PI of the study and discloses that she is the founder and owner of a social impact company called NowPow LLC, which was acquired by United Us LLC in 2021. Her other disclosures are here. Not spending much time on that slide. So food insecurity, let me get back to my notes, keynote. So food insecurity is defined by the U.S. Department of Agriculture as a lack of consistent access to food, not having enough food for an active, healthy life. It's a modifiable health risk factor that is distributed inequitably among racial and socioeconomic lines in the U.S. At this point, I wanted to tell you just a little bit more about how me, a neonatal nurse practitioner, my experiences at the bedside, not within the community per se, how I got involved in this particular research. I had a heightened interest always in the fact that buying food in the medical center is super expensive. We have a Panera and a Starbucks. And so we all know how expensive those places are to eat. We have a cafeteria. Those prices aren't cheap either. Parking at the University of Chicago, if it's not validated, is $28. And if it's validated, it's still really not free except in certain circumstances. So it's very expensive for families who have a loved one in the hospital. One of the most poignant moments for me was when I was doing the McLean Center Ethics Fellowship, was when a colleague shared a story about an unreasonably irritable family member. It was a wife of a patient in a post-op heart unit. And I know this doesn't sound like it has anything to do with school nursing, but you'll all recognize this. This woman was uncharacteristically irritable and rude every time somebody entered the room. So caregivers didn't want to enter the room. She was at her bedsides of her husband for 3 days. And what the staff didn't realize was that she only had $6 in her pocket for food. So she was trying to save it. So she basically wasn't eating, which was making her irritable and rude. When people are food insecure, they're often ashamed. There's a stigma attached to it. They're embarrassed. They really don't want to tell people that they don't know where their next meal is coming from. So when I heard about Dr. Lindau's research, mostly the Feed First stuff that Melissa is going to talk about, I became very passionate about this research and the initiative to address the issue of food insecurity. So anyway, back to my slides here, but just wanted to give you that little bit of background. Prior to the COVID-19 pandemic, food insecurity among African-American and Black Hispanic households with children was nearly double of that of non-Hispanic white households with children with a prevalence of 25 to 22% respectively, versus the 13% among white households. In one of our prior studies that included a population-based sample of households among the University of Chicago Medicine's primary service area on Chicago South Side, we found that 60% of households with children were food insecure. Going on to our next slide over here, according to Feeding America, the food insecurity rate was trending down before the pandemic. While the trend looked good, data disaggregation revealed a significant disparity still in food insecurity among Black, Indigenous, and other people of color pre-pandemic. And these rates were exacerbated, as you can see on the second part of this page, during the pandemic. So projected food insecurity in the United States. On the left-hand side, you can see the projection of food insecurity overall stratified by race. You can clearly see that there's a gap in food insecurity widening by race. Food insecurity is dynamic and it's episodic. Experiences of food insecurity range from high food security, where people are not worried about where their next meal will come from or whether the money they have will run out before they can buy more food, to individuals and families that have to have reduced food intake and disrupted eating patterns, among those experiencing low and very low food security. Feeding America establishes that more people are experiencing low or very low food insecurity due to the pandemic. And then here, zooming in on this slide, a lot of data here. Food insecurity among patients and caregivers at the University of Chicago Medicine is very prevalent as well. In 2011, we found that 43% of parents or caregivers with a child hospitalized in Comer Children's Hospital had experienced a household food insecurity over the past year. 21% of these families were also experiencing hospital-based food insecurity or not getting enough to eat during the child's hospitalization, parents often going without food. We concluded from another study of food insecurity in 2016 among caregivers and patients in the coma and adult emergency departments, and found that the food insecurity rate of as high as 46% in the past year. So as you can see on the right-hand side, and I keep repeating food insecurity, but that's really what we're talking about here. The rates are between 26 and 45% when screening patients awaiting ambulatory care in our hospital. I'm wondering how close I am on time. I have just a couple more slides. So what are we doing about this? In 2019, we were awarded a 5-year grant to study the impact of social care intervention called Community RX Hunger on food insecurity among parents and caregivers of hospitalized children. The study was funded by the National Institute of Minority Health and Health Disparities. Specific aims of our study, this funding allowed us to study the impact of the Community RX Hunger intervention on important adult and child health and psychosocial outcomes, including self-efficacy and food insecurity. While we also study whether providing the intervention, which includes like community resource referrals for food and other health-related social needs to everyone, despite food security status, will impact satisfaction with care. These first two aims included a double-blind, randomized controlled trial where parents were screened for food insecurity and randomized to either usual care or usual care plus the Community Hunger RX intervention. And then in aim 3, we will qualitatively assess caregivers' experiences with the intervention and the role that stigma might play as a barrier to resource use. So usual care, when caregivers are enrolled in the study, they are randomized to either usual care or usual care plus the intervention. All parents and caregivers are given information about food resources in and around the hospital, including our Feed First pantries that Melissa will talk about. Those are operated as part of the Lindau lab. So the components of the Hunger RX community intervention, this was one of the things that I did for the study was I screened the families that would be suitable to approach. So many families, with children, I find it hard to find healthy food, and child's hospital stay can make that even harder. So we discussed the issues of food insecurity, educating families, and also identify those with the most social risks. And then we would deliver the Hunger RX coaching ongoing to the community resource and community resource navigator to families via text message. We would also give it to them in print as well as repeated text messages. So these would be specific interventions for where that particular family lived if they were randomized to the intervention group. Oops here, and then this is just looking at so we just completed our enrollment of 640 participants, and this is just some of the preliminary data of where we were at. The analysis of all of that is still underway, but identifying, and I think do I have just another minute? I'm not sure if I do or not. I think I might be just right there. We did find that just preliminarily that most of the parents that were participating in the study from the patients, caregivers that we approached were the mother of the child, African American and Black, and 35% were experiencing food insecurity at the time of their child's hospitalization. And then I will turn this over to Melissa, who's going to talk about our food pantry system.
Hi, everyone. Thank you so much for having me. Just going to share my screen here. All right, so my name is Melissa Grana. I am a research associate and the Feed First operations lead with the Lindau lab. During my presentation, I'll be explaining why a hospital-based pantry like Feed First is important, how our model is unique, and how our model showed an increase in impact during the pandemic. So why have a hospital and why have a food pantry in a hospital? Feed First and other hospital-based food pantries aim to reduce food insecurity at the point of care. A child or adult's hospital visit can create barriers to accessing healthy food, which is why our program started 10 years ago. Our food pantry program's target population is anyone with reason to be at the medical center. So this means patients, family members of patients, and UChicago staff. Simply put, our pantries serve the people that live in our community. Unfortunately, the south side of Chicago has a high rate of food insecurity, which makes our program even more vital. And as we've seen in the previous presentation that Christine gave, our community has a population that specifically experiences hospital-related food insecurity. So this is a snapshot of a letter from our program's founder and director, Dr. Stacy Tesler-Lindau, which explains our mission statement and introduces our Feed First Toolkit, which helps others start their own food pantry program with our model in mind though. And as the name suggests, Feed First #1 priority is to feed people first. So we don't ask any self-identifying information of our clients. Our pantries are open 24/7, 365. Each one is self-serve, open access, and people are encouraged to take as much food as they want for themselves and for their families. All these qualities are what make our program a unique success. So most emergency food programs require proof of need through attestation or self-identifying info like ID, name, or home address. Or programs will have staff on site controlling food distribution and assisting in the client checkout process, meaning clients are always being monitored or watched. We feel all these requirements just result in barriers to food access and promote stigma around using free food, and it ultimately perpetuates the very issue that emergency food programs are supposed to solve, which of course is food insecurity in our communities. So because our model engages the community, we can ensure that our program serves its community members. In this web diagram, you can see the many components that drive Feed First operations. Each hub is made of people who live in the community we serve. We have an advisory board consisting of pantry clients and patients, medical student volunteers, doctors, nurses, dietitians, and researchers, the UCM Garden Committee, which consists of UChicago staff, nurses, dietitians, and groundskeepers. They work hard all summer long to provide fresh produce to our Feed First pantries. The Pritzker medical student volunteers keep our pantries shelves stocked on an almost daily basis. And of course, we are supported by the Greater Chicago Food Depository. They have been our main food supplier since 2010. And of course, since our program is developed and powered by the community, we can ensure that our program is sustainable and successful. So during the COVID-19 pandemic, our program saw a dramatic increase in operations. We believe there was an increased need to open access healthy food and that our program was able to fill that need. So between April 2020 and March 2021, Feed First nearly doubled in pantry number, going from 6 to 11 pantries. You can see here in purple where and when all of our new pantries opened on UChicago campus, the medical campus. And I would like to note our Sky Cafe Pantry, which is located next to the Sky Cafe restaurant in CCD. It's the first open access free food pantry in a retail space that we are aware of. And interestingly, it has not affected the sales of the restaurant. And the other pantry I would like to make a note of, one of our new ones, is our DCAM 3 pantry. It's in the phlebotomy clinic waiting room, and it is our most popular pantry to date. Could be due to the high foot traffic there, easy accessibility. Just wanted to point those two out to you guys though. So here, these figures kind of show the story of just how much our operations grew. Since our program doesn't require any proof of need, our main source of data for program impact is just simply the pounds of food distributed. Using this data and voluntary sign-in data, we're able to estimate the number of households and individuals that use our pantries. So this figure is from our recently accepted publication, and you can just see that it describes our impact pre-pandemic and during. On the left figure, you can see from March 2019 to November 2019, so 1 year before. we were distributing an average of 1,000 pounds of food per month. After the pandemic started and we expanded operations to the 5 new pantries, we started distributing around 3,000 pounds of food per month on average. So basically triple increase in our distribution. We believe that this huge increase in impact is all because of our model. So that is it for me in my presentation. Thank you so much, everyone, and thank you for having me. If you want to start your own pantry, my slides have the link to our toolkit. And of course, we also have links to our social media if you want to follow us, donate, subscribe. Thank you so much.
Well, thank you. I really appreciate all of your efforts today, Melissa and Christine. Just amazing work, powerful work. Know that we can be a resource to you at the University of Chicago, no matter where you practice as a school nurse. We have resources available. We've got great opportunities to do some great work with you virtually. We're happy to host future meetings and conferences to focus on some of these topics. I'd like to jump in now to our discussion, if that's okay, and welcome Stacy back as well as Vicki. Dr. Chacho's with us. She's going to be coming up as our next speaker. But Dr. Chacho, I'd love to have you be involved maybe in some of the discussion, and maybe if you'd like to read some of the questions. This one about BMI assessments, I think is very, very interesting in school children. Dr. Chacho, can you see the Q&A?
Yep, I'm here. Yep.
Love it. Okay. So I would love to kick this off and maybe ask Vicki what your thoughts are on BMI assessments in school children and supporting that delicate balance between kids that are struggling with body image, parents who might be I don't know, worried that they're going to be blamed, maybe a little shame, fear, and denial around obesity, and BMI assessments in school children in general. What do you think, Vicki?
So I didn't even know this was happening, honestly, in school, in the schools, BMI assessments. Does this happen in all schools? Does anyone know? Does anyone know?
Not all schools, but I think some.
Yeah.
I think some.
So I think that it really should be addressed more from the physician side versus in the schools. I mean, I think in schools we should focus on just providing healthy, education to these children in general. I don't think we should be talking about some of these more medical, issues with children. I think it's a little, it can be, again, crossing, problems with, feeling shamed, and I don't think it's appropriate for children to, I'm not sure how this is set, how the setting exactly works, but I don't think it's really something that should be addressed in schools, in my opinion.
I appreciate that. Lots of great input today on the discussion in the chat. BMI assessments in schools are typically mandated by individual states. Indiana, interestingly enough, does not require it any longer. But BMI is part of the Illinois physical. Nurses collect this data in schools, but they don't necessarily do anything about it. So interesting. Dr. Chacho is a pediatrician, focused on allergies and food allergies. What are your thoughts about that intersection between seeing a BMI in a child that's maybe really high, acting on it? What do you do about that? What's your point of view?
Yeah, I think this is tough. And, this first comment here, how do we balance education with the current trend of discussing weight as body shaming? There's so many factors that you have to take into consideration. Different cultures view weight differently. I grew up in a very large Italian family, and, we really look at food as celebration, and really we don't value being ultra skinny like is sometimes popular in the culture today. So I kind of grew up with one setting, but I can also acknowledge that there is a weight that just makes our health at risk. So it's a balance, and I think it's necessary for us to look out from what we have learned and to be respectful of what other cultures view as a healthy BMI, which certainly may not be the same as what I do. But, you know, I think it is important that we continue to emphasize the healthy habits, exercising on a regular basis, nearly daily, eating. Some of these things really fell apart during the pandemic, when children were just sitting in front of a computer all day long and weren't even getting the walk to school and the walk down the hallways. I think we really saw an increase in weight. But I think, you know, the more important part is really coming back to saying it's important for your health to be exercising every day to the point where you're getting your heart rate up, to concentrating on what you're eating, to not eat packaged foods, but think about those fresh, healthy fruits and vegetables as well. But I think that's where we really need to focus our attention over our BMI or really how any one person looks, certainly. I have a request here from Lori Jensen. Can you provide the recipes that we can download that are tried and true, kids enjoyed? Vicki, do you have anything written that we could share?
I would have to get that to you guys. Could I get it and give you guys some recipe stuff that I just don't have it like right here available?
If you can get it to me, then yeah, we can get it posted. That would be fantastic.
Sure.
Thank you
Not a
very
problem.
much.
I know I saw a lot of comments about recipes, so yeah, that I could get that to you guys. No problem.
Stacy, what resources, trainings are available to continue to improve our trauma skills in the school setting?
I actually was reading through the Q&A. Some of the other nurses that are participating in this actually posted these different conferences for school nurses, and they're going to have a lot of those. If you kind of Google the school nurse conferences for, they're going to have different workshops and stuff that you can do, but I can post some of, I can send those and post those out too. I think that obviously staying up on like first aid, CPR stuff is extremely important. And it really just depends on the community that you're serving, where you might feel that you have deficits. Some people are going to have a more medically complex population that they're serving. And so their kind of procedural needs in the school setting might be a little different, like seizure management, you know, you got your, you know, diabetics, things like that, and they have different risk factors involved that you might be more kind of gearing your trainings towards. And so you kind of just getting a feel for it and becoming aware of it, and the surroundings of your school is going to kind of, you're going to kind of want to gear it towards, you take that into account when you're figuring out what kind of, where your deficits are, where your blind spots are in your trainings.
Thank you. Vicki, another question for you and for maybe anyone out there participating. If you have any ideas, please post it in the chat. But as a school nurse in New York City, I provide formal and informal health education, encouraging kids eating healthy fruits and vegetables. It's fantastic. I've demonstrated kids in class making sprout salad, bean salad, mango bean salad, fruit salad. Kids enjoy the demonstration and eat happily. I am sure they do. That's incredible. Thank you. I spent my money getting all the food and dishes. I feel happy doing this. Is there any resource or funding to you know, support this incredible work?
If anyone can chime in, I'm not, this is wonderful. This is an amazing thing. And again, is that, you know, like, you know, getting kids to, you know, demos and recipes and all that stuff really can be beneficial. And I think you're doing a great job. I would have to, I'm not sure if it's like by state, but for funding, I don't know. I can't really answer that. If anyone else has any ideas about funding for this particular type of thing.
I can just say one or two quick things. When I was in grad school, at Penn, the schools or surrounding universities might partner with different schools and like elementary schools and things like that in the areas. Penn partnered with a lot of the schools in South Philly doing urban nutrition initiative. It was called Uni, and I did like a little, part of my fellowship was with that. And so we would work and we would do like farmers markets with them. We would harvest the vegetables, and then the students were empowered. They were the ones who prepared, they were the ones who harvested, and they like planted. It was a really unique and great organization. But even just looking outreaching into like the different like universities in the surrounding areas, they might already be partnering with others, and you can maybe get your school involved in it. That would be really neat.
I also wanted to point out, this is Peggy, I wanted to point out that there's an organization that started in Chicago and has since branched to the Austin area called Common Threads. Common Threads was started by Oprah chef Art Smith. They do a lot of amazing work. And in fact, earlier in the chat, if you scroll up, you'll see the link for Common Threads. They are doing a ton of cooking classes. They even go as far as to not only provide the recipe, as Vicki stated, is so valuable, but to provide the ingredients in a basket, ready to go for the family. So really cool organization called Common Threads.
Thank you. I love that idea of the gardens in the school, getting kids involved with growing vegetables. When my kids were little, they did that frequently, and I think it's a great resource.
I'm not sure how appropriate it is for me to chime in with this, just listening to this and listening to Vicki talk about recipe cards. I do something called HelloFresh, which I know is brand, whatever. But what really is nice about that, and I don't know if there would be an application for it, is again, to put all the ingredients together, or at least some of the harder to get ingredients. Like, why would you don't want to have to buy a bottle of garlic powder or Southwest spice or paprika or whatever. If those were like, dosed out for the particular recipes, a 12-year-old could make these if they knew what it was they needed to get besides this money outlay for those extra ingredients. And I'm wondering if there might be some application for that in the community that somebody hasn't looked at to implement more extensively.
It's a great idea. We, when I was in college, we partnered with the university, and the university let us take leftover food at the end of the evening from the cafeteria and then distribute it through the city and town. And the students actually volunteered and did the work, but certainly there may be opportunities in universities in your town. And I am actually aware of a program that's just launching in Chicago that restaurants are donating food that's unused at the end of the evening, and volunteers are distributing it to those with food insecurity. But I would think any school program maybe could partner with a restaurant, and if they have vegetables that are getting to the end of their shelf life, they could donate them to the school, and they could be used for demonstrations. Like a very creative program that you've developed in school.
I also threw in the chat, this is Allie, the USDA has a lot of demonstration grants that you can apply for as well. And a lot of them are specifically focused on youth and food. So that grant cycle is updated. So if this is something that you're passionate about, absolutely take those opportunities to go after. Even small dollar grants is really worthwhile if that's something that you're going to invest your time and energy in. Absolutely think about leveraging federal resources as well.
Any other questions?
Also, sorry, I just want to mention also there's the clock, which I didn't quite get to that slide, but it's a consortium to lower obesity in children in Chicago, but they also are trying to also work with other communities. So this is another resource that maybe is worth looking into. It's not just, I mean, it was based in Chicago, but now they're trying to help other communities outside of Chicago and Illinois. So this is something that you could also look for. And they've been, they try to get these healthy foods into communities, farmers markets, gardens and things like that. So I think that would be worth looking into as well. As CLOCC, CLOCC is the acronym.
Fantastic. Another comment, our local church has partnered with the elementary school for the backpack program. Children got a backpack filled with food brought in by church members for the weekend to make sure they have food over the weekend. That's absolutely, again, just an excellent example of what a strong community participation can do for a child.